towards the left side. If both the CP angles are normally visualized, cardiac shadow is within normal range. I'm trying to look actively for any soft tissue opacity or density within the left main bronchus, which is not very clear. In my routine practice, I would like to change the window of the patient, and I would also like to know that if there has been any previous episodes, or is there this is the single episode after which the child has presented with this case scenario. My concerns in this age group are that if there is an acute presentation, it could be a case of foreign body inhalation, which has been stuck. And for that, I would like to take the decubitus views in both side lower position, like left lower decubitus view and right lower decubitus view. If there has been past episodes as well, I would like to further see the previous imagings, whether this was same or not. And other possibilities which include are that it could be some mucus plugging after a recent episode of pneumonia, or it could be due to any small interrupted pulmonary artery. Pectoralis muscles are both sides are normal, so that doesn't look like the case
What
here.
you will
So
do next in this case, if suppose you are having opportunity, what you are going to
mhm.
do next, any how you will manage this patient now?
There is, I would like to take the history that first of all, that is it the acute at first presentation? And
No,
after
it's
that,
not
I will.
acute. It is since long. Recurrent breathlessness happens and not sudden acute. Then
Sir,
what
I
you will
would
do?
like to see CT chest of the
All right,
patient.
I will give you CT scan for this patient. Please go ahead. Please take a control and scroll it and let me know what are your findings.
Okay, sir, I would like to take from the start. So it is starting from
Yeah,
here.
it's the yeah, yeah. This is the starting point. You can start with that.
Okay, so these are CT chest lung window images in the of the same patient, in which I can appreciate that there is left upper lobe collapse, and there are multiple ill-defined patches of consolidation, ground glass opacity seen in bilateral basal regions. They are more towards the periphery of the lung, and there are some prominent there are some prominent there's some bronchiectatic changes as well located
Mhm.
in the parahilar region. I can also appreciate that in both lung parenchymas there are multiple tree bud opacities seen. Um, Sir, can I see the coronal window of the patient?
There is no availability of corneal window, but you are on right track that I can tell you. And now you have to just join the dots, like recurrent infection and bronchial dilatation in a child, and there is some collapse. What it makes and how you will manage this
Uh,
patient.
Sir, my concerns are that it could be tuberculosis. And secondly, I'm thinking of any mucus plugging secondary to
Mhm.
any chronic asthma, resulting in allergic
Any genetic
bronchopulmonary.
condition which causes mucus plugging?
Cystic fibrosis is the
Okay.
it can be an early presentation of cystic fibrosis in which there is not a gross dilatation of bronchi. So in this case scenario, I would like to further advise IgE levels, the level of eosinophilic count in the blood, and I would like to advise a test for cystic fibrosis for patient as well as sputum for AFP. to rule out
All right.
all the three causes. Number one, my differential is cystic fibrosis. Second possibility that it could be allergic bronchopulmonary aspergillosis, which is complicated the asthma. Thirdly, it could be tuberculosis because from the background where I've come from, we would straightly label it as tuberculosis. So these three, and next the further three tests are going to differentiate between the causes.
Okay. All right. So you did very well on this case. Only thing which I would like to tell you is, you could have picked up the upper lobe collapse left side, the Luft seashell sign on the
Mm,
first attempt over here. If you could see that, there is a Lucian sea surrounding it. So if
mm,
it could have been picked up, it would be the great, but it's fine. So basically, if you are able to pick it up, it's fine. But if you are not, then you should know how to manage that patient. So examiner won't give you the next investigation directly. You need to draw it from the examiner. Like, I hinted you and you draw the CT. The problem with this exam is more the hints, your marks will be deducted. So there is an
mm,
option. They will, mention that the candidate was able to pick up with some amount of help. If you read the scoring, then your score will be decreased. So try to
mm,
get it. There are few cases. 2B exam is the kind of the picturesque version of 2A exam only. So whatever the topics were there in 2A exam, that will be converted into pictures in 2B exam, nothing else. So there are few particular scenarios are there. Whenever you see this kind of, recurrent infection and collapse, always think like that. Your way was excellent, but you could have done it very fast as well if you know about this case. These are the standard cases which are coming in most of the exams. So just try to understand the scenario. Otherwise, everything was fine, and you could have just said that I will refer this patient to the pediatric chest physician and as you said, that to ascertain the three causes, like what you have said, and they will do the rest. Something like
mm,
that. You are not supposed to tell like what immunoglobulins and something. It will be too much lengthy. You just direct to that path. That's all.
mm.
Okay. Otherwise, everything was good. So next case, last case for you, I think, because we are running out of time. I will give you this case here. This, if you could take, please. And I will give you the history for that.
Okay.
Yeah,
Uh,
just a second. So there is a head trauma in 45-year-old male, and after head trauma, there is headache, severe headache. Please
hmm.
take control and go ahead.
Okay. This is a CT head axial section in a patient, particularly based on the base of it is partially not completely seen the brain and axial plane. So only this they are
If you
given
could go
different.
ahead, then it will be fine. Yeah.
It is going down. Sorry.
Yeah.
I will just take a moment to scroll in this plain CT brain axial section. In this, I can appreciate that there is a subgaleal hematoma in the vertex region of the skull, and there is some effacement of sulci gyri in the right right parieto-temporal region. Uh, there in my first scroll, I was not able to pick anything, to be honest. So I will try to go for my review area, starting from the base of the skull. I will try to look slice by slice to rule out any possible uh, any any possibilities. What have I done?
Yep. Sorry, I think something is going on. Just a second.
There is this my screen or
No,
yours?
I think it's my screen. I'm really sorry for that. Just a
Okay,
second. My screen is gone, I guess. It's give me 1 minute, yeah.
it's okay, sir.
It's okay, sir. Just unsharing my screen. Give me 1 minute. Yeah? Now I'm resharing my screen, and then we can go ahead. Apologize for this. I don't know how it had happened. Are you able to see my screen now?
Yes, sir, but no screen, no quiz is there. Yes, I can see it now. Sir,
Now it's fine?
it's fine, sir. I'm requesting for control once again.
Yeah, please. Yes, please. Now you have control. Please take.
Okay, sir. Yes. Um, so I'm trying to look for any associated findings in this patient. All I could appreciate is a small hematoma in the vertex region. Sir, can I go for a bone window? Because in this current study, I was not able to find any significant midline shift, any contusion. I'm also trying to look for any subdural hematoma or any isodens hematoma collection, which is not there. There is no uncal herniation, and the bones apparently look normal, but I would like to see them on the bone window.
Okay, I will give you bone window. Please go ahead with bone window.
Okay. These are the, I'm going lower down, just let know. It's okay. So there is mastoiditis on the right side. In the base of the skull, I cannot appreciate any fracture through the petrous bones. There is mm,
Do you know any causes of severe headache in after trauma or anything like that? What are the causes?
the severe headache is can be related to vascular causes. Um, like there could be any bleed, any already going on aneurysm rupture, or it could be due to it could be due to edema. A significant brain edema can also lead to, but in this I'm not able to appreciate anything. I would like to look for any fullness in the region of orbital region, which is not seen. There is no evidence of any fracture. Sir, is there
What
any
are the
other
vascular
studies?
review areas? What are the vessels, various kind of the vessels, and you used to look at whenever you are assessing headache? One you
Um,
said arteries. What are the others?
Veins. I should look for veins as well. Um Sir, this area, they are not symmetrical. This this region, can I go for the
Yeah,
soft
you
tissue,
can take whatever, which you want. Axials, the
the
soft.
yes,
Yeah.
axial windows again, because I appreciate that there is some um, asymmetry seen in the bones in that region of right occipital bone.
Hmm.
And there was some hyperdensity in the right mastoids as well. And I'm concerned for some heterogeneity in the heterogeneous foci, hyperdense or hypodense in this region. It could be due to any sinus thrombosis post-trauma. in this region. There's a small air focus as well, this here.
That was the
And
finding. Okay, now you got it. I'm sorry, I'm stopping it because the time is less. So
said
chances of
CT.
see, this was the pickup finding. Okay,
Mm-hmm.
if you go here, this was the pickup finding. So if I would be you, how I will approach this case? Whenever I come to know about headache, my clinical question is headache post-trauma. I will scroll the scan. So, okay, my clinical question is headache. I'm looking at the scan once and then I will come back with my findings. Then I used to look at the case. I will look at the first subarachnoid hemorrhage areas. And I don't see any hyperdensity along the cisterns or the any traumatic site. Then I'm looking for any vessel damage. I don't see anything, no any intracranial hemorrhage as well. Now I'm looking for the venous sinuses because the cavernous sinus or any dural venous sinus thrombosis could be the cause of headache. So I'm looking at the symmetrical areas of the venous sinuses, but here I can see that there is something problematic. There is air foci within the sigmoid sinus, and I would like to raise this concern, and this is not confirmed, but I would like to raise this concern, and I would like to arrange the CT venogram, contrast CT venogram for this patient. So once you say that, they will give you the contrast CT venogram, and once you get the venogram, then you can see that, see, there is nothing over here as compared to this, but
Mm-hmm.
here there is contrast. So that's the finding, and this is how you can approach. And then you can say that this is a safety finding, immediate concern. I will raise the issue to the referring clinician and requires urgent stroke team referral or review or urgent vascular team review, something like that. But yeah, it was a bit tough case. But you need to kind of develop this kind of easy case, but rare areas, how to assess them. So that would be my next teaching point from this case. There will be easy cases, there will be safety finding cases only, and you need to develop your review areas for that easy finding case. Because once you miss safety finding, they will simply write that you are unsafe radiologist and you are gone. That's the problem with this exam. However good you are at other cases, this kind of the small mistakes sometimes may make you unsafe radiologist. And some examiners may directly write that. So that's the problem. So I hope you are getting everything, and I hope this session is nice for you. If we are getting more time, I will go with the further cases. But as of now, we will go with the candidate two. But candidate one, your preparation is good. You are doing really well. Only three things I would like to tell you: focus on less, management things, like just try to divert the patient, try to focus on the causes, the common scenarios which you understood during your 2A exams. Just try to remember that scenarios, two or three top differentials, and you just look at that areas only. First, make your case in your mind, and then look for the review areas. Most of the times, the safety cases are like that only, and that will make you or break you. If you got all the safety cases right, I think your exam will be cleared. But if you got one wrong, then there will be a problem. So don't miss on safety cases. That's the only thing which I would like to tell you. All right.
Okay, thank you so much, sir,
Otherwise, everything
for your
goes good.
points. Thank you.
Yeah. So next candidate, I'll just not sharing my screen and will load your cases. Just a second.
Hi.
Yeah. 1 minute, please. Are you ready, candidate two?
Yes, sir.
You are not audible clearly. You need to raise your voice a bit.
Uh, my voice clear?
Yeah, now it is clear. Perfect. So, candidate two, this is your case number one, and I will give you a bit of history. The patient is having dysmenorrhea, and you have to ask me control, and you can scroll it. You know how to ask control?
Yes, sir. I
Yeah,
have requested
perfect.
for control.
Yeah, you can use up and down arrows. And as I have explained to candidate one, you can assess this case.
Okay, these are grayscale transvaginal ultrasound images of a patient having a history of dysmenorrhea. I can appreciate the uterus. It is anteverted. There is um, I'm looking at the junctional zone. There are small irregularities at the anterior aspects of the junctional zone. The loss of hypoechoic line of the junctional zone, and also on the color Doppler image, there are increased vascularity along the anterior myometrium. Um, I would the both adnexa in these images are not provided. In summary, in this patient, there is appreciation of loss of junctional zone along the anterior uh, aspects with the heterogeneities along the anterior myometrium showing increased vascularity. So my principal diagnosis in this case is adenomyosis with a focus of adenomyoma. Other differentials in this case would be developing fibroid along the anterior myometrium. So I will inform the findings to the referring gynecologist and suggest referral to the gynecology team. Also would suggest MRI of the pelvis for further confirmation of my findings. Thank you.
All right. Yeah. Perfect. All the things picked up, but there are some things which you can improve. That is in the knowledge part, knowledge domain. You could have said that because it was there in front of you. Examiner wants to hear that there is asymmetry in the myometrium. Have you spoken that? I don't know whether I have missed it or not. Because you see
Heterogeneity is
the
along
anterior,
anterior myometrium.
sorry?
I said heterogeneity is along anterior myometrium.
No, asymmetry, I mean the size, the thickness, the asymmetry. The anterior wall is enlarged as that of the posterior wall. Otherwise, heterogeneity, you have spoken that I know. Otherwise, everything was fine. So, and you managed it nicely. You send it to the gynecology team. You also discussed regarding MRI. So, yeah, you picked up very well. You managed all the tick boxes nicely. Perfect. Next case. So I will give you history for this case and then you can go ahead. So this is a 50-year-old male with abdominal pain, nausea, and vomiting. You can take a control, scroll it, and just go ahead.
Sorry, I have given up control. I have requested. I
You
have
need to
requested again.
re-request it.
I have
Yes,
requested.
no
Yeah.
problem.
Yeah, so these are axial sections, contrast enhanced CT abdomen, and oral contrast is also given because I can see the oral contrast in their stomach. In the lung bases, I can appreciate that there is a nodule in the right lung base. I'm looking down. There is also, yeah, yeah. I'm scrolling down in the left side of the abdomen in the region of the jejunal loops. There is invagination of one bowel loop into the other, favoring intussusception. I am looking for any lead point causing this intussusception. And there are small mesentery with small lymph nodes going into this in the recipient with a heterogeneously enhancing area invaginating into the bowel loop. The visualized liver shows no focal lesion. The spleen is also unremarkable, as is the pancreas. I'm going down. Both kidneys are excreting the contrast normally. There is sludge in the gallbladder. Yeah, going down. Also, there is marginal thickening of the bowel. Uh, Incidental note was of a small cyst in the right kidney. In the pelvis, yeah, I could not see any gross abnormality. Um, so, in summary, in this patient, there is a presence of invagination of one loop of the bowel with the other, um, showing with a small nodule in the right lung base. In my routine practice, also there are multiple deposits in bilateral lung field. This likely suggests metastasis. In my routine practice, I will go through the lung window and also like to see on the coronal images to further confirm my findings. However, confining to this case, as there is intussusception in the left side of the abdomen, likely jejunal with the thickening of the bowel and invagination of the mesentery showing lymph nodes. So the cause could be lymphoma causing intussusception with lung metastasis. There was a small non-enhancement of the bowel wall I was suspecting, so there could be some element of gangrene. As this is emergency, first I will pick up my phone and inform the referring physician about the finding. Will suggest referral to the surgical team, and further I will suggest referral to the gastro-onco MDT. Also suggest staging CT and PET CT in this case. Also like to see the bone window available in this case. Thank you.
All right. Nicely picked up the main finding. That was fine. Managed it nicely as well. Now you check that you can't see the enhancement properly, like as that of arterial portal phase, because it is kind of delayed phase, where the excretion has already started. So less likely you would be able to comment on that. Now, what are the causes where, adult intussusception happens with pulmonary metastasis, and where you need to look next? These are the common scenarios. Have you read that kind of questions in 2A? So do you have anything in mind? I will give you one chance if you could pick up.
Sir,
Adult
this could
intussusception.
due to bowel lymphoma, as also
Another?
other differentials would include adenocarcinoma of the bowel with the lung metastasis, and
Any dermal malignancy,
Never syndrome.
No, it's a malignant melanoma. Okay, which
Okay.
is very common in UK as well, and which is leading to this kind of metastasis and intussusception. If you could check that over here, there was a lesion, though it was not dermal, but this lesion, if you could have picked it up, it would have been better. Are you able to see this lesion over here? Uh, are you able to follow my arrow behind the iliac bone, right iliac bone?
Yeah, this one.
This, yes, yes.
Okay.
Okay, so that was another lesion which I wanted you to take it up, and I wanted you to also correlate it with the malignant melanoma. Don't worry, this is kind of, because we are not accustomed to this system. That's why it is difficult to pick it up first. Otherwise, UK candidates, they are trained in such a way that they will speak up this diagnosis first. So that's why I have put this case up. And this is a very important case. Mind that. Otherwise, everything was fine. You raised the concern, you said the management, and you also said the staging scan is required. You also said the bone window, etc. was fine. But just this thing, this particular scenario, just keep in your mind. Okay. And then next case. I will give you the history for this case, and you can go ahead. It's a 12-year-old child, and um, just a screening radiograph for some other purposes. Are you able to detect something on it? We'll give you a bit of zoom in.
So please refrain. Can I ask candidates to refrain from writing? Because this is frontal. This is just radiograph frontal projection of pediatric age group patient. I At my first glance, I could not make any lung pathology. There was no pneumothorax or pneumomediastinum. Both costophrenic angles were clear. the visualized bone. Although the spine was not clearly seen, the visualized, yeah, I could see that there is inferior rib notching, bilateral inferior rib notching in the upper ribs. This one, and this also on the left side. I can see inferior rib notching. So these could be, and also I cannot see the aorta. The heart was also somewhat enlarged. Um, so this could be due to coarctation of the aorta. But yeah, in this, I will also like to see the bones on the right side. I think there is some lucency, lytic region involving the rib on the right side. 1, 2, 3, 4. There is also bulky right hilum. So in my routine practice, I will further like to see the history and also will like to see the comparison with the previous imaging if available. And
This is a screening. First time just came out of the screening, and the findings are there. So now what you will do next?
I will do cross-sectional imaging in the form of CT chest.
Mhm.
And
Is it
also,
required at the moment?
at first, if I could not see any finding, I will take help from my senior colleagues. Um,
I think okay. All right. So yeah, you picked up correct. Inferior rib notching. You have to say that aortic knuckle is not seen, and it was coarctation, but then you missed your way. So this kind of the cases will be asked where there is only one finding, and they want to check that whether you are still safe or not, you are still confident or not. If I would be you, I could have said that in this screening film I can see that there are some inferior rib notchings. I can't see aortic knuckle very nicely, so I think that this patient could be having coarctation of aorta. That could be my first differential. Meanwhile, there are other causes of rib notching which I need to ascertain, like hypothyroidism, all that things, and I will just have a look at clinical profile to rule out all the other causes. And if they are not, then I will refer this patient to the cardiovascular physician or the vascular surgeon, and to decide the further workup in this patient. So you just have to transfer from one pathway to another pathway. They will decide what to do, cross sectional, not this, that. Your job is this much. Okay, so this was very straightforward question, but most of the candidates does like this. Once they pick up the finding, then they will feel like, during the exam, there is stress, obviously, that there must be something else. I'm missing something. Don't worry. They will ask you only two-way type of the cases, but in the picture manner. Just mind that. Just remember that scenarios only. Okay, otherwise you will do blunder. They will mention that this radiologist is not safe, is speaking too much, saying a lot of things. Your marks will be detected. So just be sure. And in this kind of small cases, short cases, they will be having some additional questions. So they may ask you, what are the causes of rib notching? So in small cases, you have to read and remember some additional stuff as well. Okay, some causes or some how the rib notching happens. They may ask you a bit of the pathophysiology that was asked in many exams. So that's how this kind of the cases are dealt with. Okay. You're getting my point. See, it's like everyone will teach you cases, but it's not about cases. What I'm trying to tell you is you develop that approach because, in UK, the thing is they are expecting us to become a robot. What they are thinking is, in human mind is very nice. They can do wonders, but when it is fatigue, there may be chances of error. So they don't want to take any risk for their patient. So they are trying to make their trainee or doctors like that whatever the strategical things are there, this kind of the features, you have to speak this thing up and you have to refer to this person. So then and then workup will gonna go ahead. So it is like a chain which you have to follow. You need to make yourself a robot in particular situation, that I will look at this finding. If screening type of film comes, there are four or five things which, it can be coarctation, it can be something else, like maybe some nodules might be there in screening kind of film, can be mastectomy would be there, some clavicular pathology could be there. So there are fixed things for each and every type of the films. You just remember that, just have that checklist in your mind and just look at them first and then think about all the other things. That would be the best approach for your exam and for the UK system where they need robots. Okay, now
Okay.
next is for you, and I will give you the clinical features for that. It's a 45 years old male, and there are occipital headaches for this patient. Okay, and vomiting as well as dizziness. If you could take a control and scroll it.
Okay, this is a CT head, axial sections, a brain window, 40-year-old patient having vertigo and headache. Um, I can appreciate that there is a well-defined cystic lesion, well capsulated in the posterior cranial fossa involving the right cerebellum. It is causing mass effect on the midline vermis, and also there is marked compression of the fourth ventricle uh, with resultant mild hydrocephalus. Uh, they, yeah, in the superior supratentorial location, uh, there is no evidence of any hemorrhage or ischemia. There are hyperdensities in the superior sagittal sinus right over here. However, um, the so in summary, in this 40-year-old patient, a well-defined cystic lesion in the posterior cranial fossa in the region of the right cerebellar hemisphere with the marked compression of the ventricular system. uh, my principal diagnosis in this case is likely a abscess, brain abscess. Uh, uh, so with developing hydrocephalus, as this is emergency, I will pick up my phone and inform the referring physician. Will suggest a referral to the a neurosurgical team for urgent management. That would be in the form of ventriculoperitoneal shunting. Further, I will suggest contrast enhanced CT or MRI in this case to further see the wall enhancement in
I'll
the
give you
cerebral
MRI.
cavity.
I will give you MRI. You requested me MRI. We have MRI. I'll just give you MRI. Okay, this is the sequence for you.
Okay, this is sorry, this is axial T2 weighted image of the same patient, further showing hyperintense cystic lesion in the right cerebellar hemisphere, causing compression and mass effect on the midline vermis and also the fourth ventricle. Uh, mm, um, um, I am looking at the dural venous sinuses. These these look fine. I will like to see the on the contrast enhanced imaging for further evaluation, also the figurative imaging if available. Other differentials in this case would be some pilocytic astrocytoma. Can you go to the contrast enhanced
The
imaging?
patient is adult. The patient is adult, 45 years age. What are the differentials, please? Directly, let's go to the differentials and management directly.
Okay, okay, this could be some cystic neoplastic lesions, likely hemangioblastomas or pilocytic astrocytoma. Other differentials include cystic metastasis, as this is intraaxial lesion. So, if this would be extraaxial, then my other differential would be arachnoid or epidermoid cyst. Um, uh, so, can I have
How we will manage?
so I will inform the findings to the referring physician and will suggest referral to the neurosurgical team for further management. Also, as this is emergency, I already said that there is marked compression of the fourth ventricle. So when there is urgent need of ventriculoperitoneal shunting. Also, whole of the yeah.
All right, no problem. So you were right, no problem, but there is some UK way of doing this. I will tell you that. So what they are doing is, okay, I can see that there is a CSF density lesion, which appears to be cystic, and I'm looking for any internal soft tissues within it. So I can see that there is a hyperdense
Yeah.
soft tissue within it, which this is the contrast and it is enhancing. So then yeah, I can see that it is blocking the fourth ventricle. So there may be chances of hydrocephalus, which is developing at the moment, bit of the prominence of the temporal horns are there, which supports my diagnosis. Now, in this case, I'm suspecting with the age, the first differential would be cerebellar hemangioblastoma because there is a hyperdense enhancing vascular
And it
nodule,
was not
and
provided
I'm
contrast country. Yeah, sorry, I was not
yeah, so
provided.
you need to say that, whenever you are saying, if do you have any contrast city images, please? Something like that you need to say. So that's where I'm taking you. I'm taking you all that things which you need to do during exam, by showing you cases, by making you commit the mistakes so that in real exam you will not commit that. Okay, so whenever you are seeing that, you can ask, I would like to check any contrast scans images available or not. So if they are having, they will give it. They say that no, no contrast images. Then you can say that, oh, whenever you are coming to that kind of case, you need to speak differentials, as you said. My top three differentials, as per the clinical question, could be cerebellar hemangioblastoma, or could be this or that. Never commit on abscess very fast unless there is a fever, unless there is acute presentation, something like that. If the examiner speaks that, then and then you should commit that. Otherwise, you can say that, oh, yeah, that can be included in differential, but I would like to assess with the contrast image on the CT or else MRI image. Whatever you will speak, they will give you that. If you have spoken contrast CT, I could have given you that. If you spoken MRI, that's why I've given you that. So now the UK way, another way is whenever you are suspecting hemangioblastoma, VHL is kind of peculiar for the Royal College. So you need to speak that this patient could be having a von Hippel-Lindau. So I may ask for the any family history in the patient for the similar diseases. I would like to refer this patient for the multiple workup and MDT discussion. This kind of the patient, you need to speak this word. You need to send this patient to the MDT pathway because this is like a complex disease which involves multiple person to discuss. You raise the hydrocephalus, that's fine, the urgent, but afterwards everything will be decided by the MDT. In UK, what happens is single person won't take responsibility because if something goes wrong, that will be a problem to him. So everyone will get together, will sit in a room, will decide what to do for this. Like the surgeon will look at the any possibility of resection. Another person will oncologist will look at possibility of VHL. They may plan further MRI spine, further thorax abdomen pelvis CT for the neoplastic staging or something like that, detection of another tumors associated with it. Genetic people will say will do the genetic counseling and testing, something like that. So you have to say that you will refer this patient to MDT. So you may lose mark on the safety finding because you have it would be classified as a scattergun approach in this they will mention in your mark sheet as a scattergun approach, that you have spoken up any finding, you have spoken up anything which doesn't make any sense in this particular clinical scenario, and you will lose mark. And you haven't directed the patient towards MDT, again you will lose mark. Even though you know everything, but as per UK guidelines, as per their competency, you may lose mark. So that's what this case will is teaching you. So my purpose for today's cases are, you do mistakes, you understand what the UK people requires, and that's what we are, kind of focusing on. The last case for you, if you pick it up early, just pick up the diagnosis and management, then I can show you two cases which are important for everyone.
This is a frontal radiograph of the hand of pediatric age group. I can appreciate that there is a juxta-articular osteoporosis involving the metacarpopharyngeal joints and also carpometacarpal joints. There is no evidence of any fracture in this case or any lytic lesion. So, like this is mm, a case of juvenile idiopathic arthritis. Other differential in this case would be rheumatoid arthritis, um, or other differentials
I'm
include.
just stopping you. Are you able to see this
Yeah,
angulation?
okay. There is some lucent line involving the uh, proximal metaphysis of the proximal phalanx, um, and also I think there is also soft tissue swelling, surrounding soft tissue swelling. So I would like to take the history of the patient, whether there is history of trauma. Uh, uh, if there is any history of trauma, then this could be due to Salter-Harris fracture type 2, or if there is any history of infection, then it should be due to some
Okay,
osteomyelitis.
so Salter-Harris type 2, how you will manage this patient?
So I will inform the finding to the referring physician, will suggest referral to the pediatric orthopedic team, immobilization of this
All right.
finger, and also repeat follow-up imaging.
All right. No, perfect. You got it right, but you didn't pick it up earlier after hinting you, after, completely saying you that. Otherwise, you should pick it up. Whenever you get pediatric hand, always first look for fracture. So what I'm advising you is, or even we are going to discuss in our further classes, what could be the sequence of abnormalities you need to see in a particular image, in a particular scenario. You need to remember that thing. I will also, in the end, I will also say you by which book you can do that. By following which book you can kind of remember that as well. So no problem in that. But for every imaging, you should have certain differential skip in your mind. You won't be able to remember it. So what you have to do is, if you have 3 to 6 months in your hand, just every day do it so that it will be in your automatism. It will be in your spinal level. Try to practice that so that you don't have to put any effort while doing exam. It just comes out like a automatism, like a robot. So that's what I can tell you. Every film has a particular 5 or 6 diagnoses in particular scenario. Just remember that, you will be fine. This patient, you just need to pick up the finding and tell me what do you think very fast. Okay, 90 years age and diabetic patient with acute abdominal pain.
Okay, this is frontal radiograph of abdomen. There is a gas within the wall of the bladder, uh, uh, and also there is gas fluid level. Um, so likely this is a case of emphysematous cystitis. Uh, as the patient, the history is also suggestive. So as this is emergency, I will pick up my phone and will inform the referring physician, will suggest referral to the urologist for further management. In the rest of the imaging, I can see that there is a calcification, calcified spot on
All right.
along the
Okay.
right
No,
ventricle.
you did well. You did well. Perfect. I'm sorry I'm going a bit fast because I have to show you all these important cases. Last cases for you. Last case for you. If you could just take a scroll and just give me diagnosis and management for this one. This is also very important case.
Okay, sorry. Yeah, there is a cystic lesion in the posterior to the urinary bladder. I am looking at its connection with the uterus. It shows it is appearing hyper intense on this T2 weighted imaging. There seems to be two uterine cavities, so likely this is a case of hematocolpos in one of the horn of the in the uterus didelphys. I would also like to see on the T1 weighted imaging and also on the axial imaging. Also like to take the history
I'll
of
give
the.
you T1 weighted image. Yeah, just a second. This is your T1 image. So what's your final diagnosis and how you will manage this patient?
Okay, in this T2 T1 weighted axial image, again I can appreciate that the cystic lesion, this is communicating with the vagina, and also there is evidence of this is communicating with the uterus. So likely this is a case of hydrocolpos. So I will inform the finding. The referring physician will suggest referral to the gynecology team for further management in this case.
Okay. So if I would be you, I could have spoken like this. I would first ask whether the patient is having a, I would ask to the examiner whether the patient is having a normal menstruation or not. The examiner will say that, yeah, she's having normal menstruation. Then now I can focus on that. That yeah, okay, there are two canals, two endometrial canals, two cervical canals, and maybe opening in vagina. So, but one of the side of the cervicovaginal canal is completely obliterated, and which is showing shedding sign on T2 image. So it could be a hematocolpos. But on the other side, I can see that it is normal. So there are two cavities. So it could be uterine didelphys uterus with two cervix and two vagina. And another thing is, what I will look at is any other abnormalities like vertebral anomalies or something related to the other associations and kidneys as well, if it is uh, seen. And I will refer this patient to the gynecology team. That's all. So you need to speak up this word, didelphys uterus and bicollis or unicollis. Whenever it is unicollis, then you have to say unicollis, bicollis, then you have to say bicollis. This would be the mark getting point. They want to know this knowledge from you, whether you know the differences between the unicollis and bicollis, didelphys, bicornuate, septate, all that things. All right. So you need to give that answer. I hope this uh, is beneficial for you, and we can go ahead with the candidate number 3
Thank you, sir.
afterwards. Yeah.
Excuse me, Dr. Mehta. Candidate 3 hasn't joined in yet. So would you please start with candidate 4? And after candidate 4, if candidate 3 hasn't joined in yet, there is a volunteer who's happy to take his place. So hope this will be fine.
All right.
Okay.
Yeah. Just give me a moment. I'll change the playlist and come back. I'm just stopping the screen share. I'm sharing my screen, and candidate 4 is ready.
Yes, Doc, I'm ready.
Yeah. Are you able to see my screen?
Yes.
Perfect. So this is first case for you. And this is 55-year-old male patient presented to the emergency department with non-specific abdominal pain. How you will manage this patient?
Okay. I've been provided with frontal radiograph of mature skeletally patient. I will have a look for the chest X-ray. This patient is coming with abdominal pain, non-specific. Just I will have a look as I couldn't see something clear in the X-ray. I will go for check the parenchyma. I can see that both parenchyma and both hilar appearing normal. I will go for the reviews area. Both lung apex appearing normal, both costophrenic angle and also retrocardiac appearing normal. Mediastinal and trachea is detecting within the midline. I will have a look for the bone. I couldn't see abnormality noted within the bone. Maybe I can see that there is some evidence of reticulations with fine bronchiectic changes noted within the left upper lung parenchyma. But I couldn't see any other finding rather than this. I want to look for the soft tissue within the abdomen, as the patient is coming with abdominal pain.
Okay. Anything in chest X-ray? Any other thing are you able to see?
No, for this, I will look for the soft tissue also. In the chest, I couldn't see abnormality within the soft tissue. So I really couldn't appreciate marked abnormality within. Maybe there is here in the left lung something, but I'm not sure about it really.
Okay. Would you like to look at the right lung field very carefully, especially the peripheral areas?
Yes, in the peripheral, I can see that there is bilateral. There is two well-defined pleural-based nodules related to the lateral aspect of the pleura. I couldn't see that there is evidence of fracture ribs noted or destruction of the ribs related to it. So in this case, I want to check the CT for this patient to see
Okay.
if
I'll give you CT.
okay, this is
Please
the
go.
scanogram. Okay.
You can take it, cut the control, and you can
Okay.
scroll it from here. You can request me control here.
Okay.
Yes, please.
It's not just 1 second. It's not scrolling.
You need to go with the arrows, up and down arrows,
Okay.
not the right and left arrows.
Yes, I'm
Can I
using
scroll
the
it for
arrow.
you?
Okay, okay,
Perfect.
it started.
You are doing.
Okay. This is the axial CT for mediastinal window for the same patient. It's with I can see the lesion that I noted within the X-ray. It's a pleural-based lesion with hypodensity, soft with hypodense. In my routine practice, I will check this Hounsfield unit. Maybe it's fat content. It's just I will go more to check if there is any other lesions. Okay. Okay, it's only for the chest and the upper abdomen. I couldn't see something in the upper abdomen. So I will go back to this lesion. It's only this well-defined hypodense lesion with fat content. I believe it's fat content because it's low density, and I couldn't see
What's your
that there is.
diagnosis?
Okay, it could be a pleural lipoma. Also, it could be pleural fibroma with no, sorry, it's
How we will
lipoma.
manage this?
I will convey my finding for the chest team for discussion for this and follow up maybe if it's approved to be according to their appropriate management plan.
Okay. All right. So few things. First of all, you just missed that thing. So whenever this kind of thing comes up, like non-specific thing, just keep in your mind. You first have to speak as per the clinical question. So there is an abdominal pain. There is erect chest X-ray. First finding you should look at is always pneumoperitoneum. Okay, or air under diaphragm, because the main concern is abdomen. We are not here to detect diagnosis, we are here to manage a patient. So whenever that comes, you should say that there is no pneumoperitoneum or no air under diaphragm. That should be the first wording. After that, you should look at the film. If you are not able to see anything, you should say that I can't see anything over here. I would like to look at my review areas, but I can see that there is a pleural-based density or opacity along the right pleural margin. So I don't see anything related to the abdomen. I can't see any radio density in the gallbladder region, and stomach gas shadow is also fine. So rest findings related to the clinical concern, I'm not able to see, but I can definitely see that there is a mass-like lesion, pleural-based opacity. So in that particular case, I would like to inform this finding to the referring clinician. I would like to tell them that this patient deserve CT scan thorax plus abdomen to assess the abdominal causes as well as the thoracic lesion as well, so that we can assess this patient further on. Something like that you need to say, so that it will allow you to manage the patient in terms of the clinical question. You direct it towards that pathway, and you also raise the concern, and you guided the next intervention or next scan. After that, once you have CT scan, you have looked at the scan, you need to say that, okay, I can see that there is a pleural based fat, everything was fine. In the end, you need to say that I will refer this patient to the MDT with a note saying that there is no definitive internal aggressive potential, no any rib erosion, that findings, that pertinent negatives you need to say. No any other similar lesion. So it may be a low grade or benign lesion, but I do recommend MDT referral to decide what to do with this lesion further on, whether to biopsy or whether not to biopsy, something like that. So you are referring this patient to the MDT, and they will decide what to do next. But you have said all the pertinent negatives, that it is not aggressive, that you need to say. And further on, I can't see anything in abdomen, but I need the full scan to assess whether any cause related to the uh, uh, clinical features are there, or it's just a non-specific dyspeptic episode. That's all. You getting my point? How to say, how to
Yes,
manage this patient?
yes, yes,
Any
doctor.
questions for this?
No, no.
So keep in mind, whenever you see something mass lesion, something complex thing, divert it to the MDT. Okay.
Okay,
So you have to
okay,
say such sentence, I will inform or I will write a note to the referring clinician that this patient should go into the lung lesion MDT, something like that. So you are also telling clinician to send this patient to the MDT. Okay?
okay.
Something like. Now, next film for you. And the clinical features for this is 17 years old male, 17, with sudden onset of abdominal pain. If you could please take this case for me.
Okay, this is a frontal radiograph of mature skeletally patient coming with sudden abdominal pain or acute abdominal pain.
I'll give you both the films. I'm just sorry.
Okay.
Yeah, go ahead.
Okay. In the first X-ray, I can see that there is no evidence of there is evidence of multiple small bowel dilated, noted within the the left upper quadrant of the abdomen. However, the lung appearing normal. There is tiny multiple small nodules noted within the lung. Just I will go back to it, but because the patient is coming with severe abdominal pain, I will go for the next X-ray. In the next X-ray for the frontal abdominal radiograph, I can see again that there is evidence of multiple bowel loops, which appear to be large bowel dilatation, as I can see that there is evidence of hostrations detected within the right upper quadrant abdomen. For me, it's giving the appearance of embryosine, which could be cecal volvulus, as I couldn't see also that there is any evidence of gas noted within the right side of the abdomen. I couldn't see that there is evidence of small bowel dilatation. And also I couldn't see that there is evidence of descending bowel gas, descending loop, descending colon.
What do you think
So
what it could be and what you will do next?
I think it could be cecal volvulus. And I will arrange for CT for this patient for confirmation of the diagnosis.
Okay, let's check the CT and you can tell me what are your findings. Just a second.
Okay.
Please take the control and scroll it.
Okay. Should I have the should I ask the control again, or are you ready?
No, it's fine. I think it's in your hand.
Okay. Okay. This is axial cut CT abdomen portovenous phase for the same patient for lower chest and the abdomen. While I will scroll and then I will comment. Okay. While I am scrolling down, just okay. While I am scrolling, I will go back to the interest area as it is the main concern for me, this region. I couldn't see the ascending colon in its normal position, and there is evidence here of dilated colon. Mostly this is a cecal mostly this is a cecal part of the ascending colon. Just I want to look for a spiral sign for the vessels and the mesentery. I want to okay. This is the intestine, and all the small bowel appear collapsed, and also the rest of the large bowel appear collapsed. Only this the region that appear to be dilated. Okay.
Okay, so what's your diagnosis and how you will manage this patient now?
Mostly this is a cecal volvulus, and I couldn't see that there is any evidence of pneumatosis intestinalis or pneumoperitoneum. However, I would check in the lung window. So I will convey my finding urgently for the GIT surgical team for discussion and appropriate management.
All right, perfect. This case you did really well. I don't think so there is any problem. So next case we are going towards.
Okay.
And yeah, you can take it. This patient is having back pain.
Okay.
And it was gradually increasing.
Gradually increasing. Okay.
Over 2 months.
Okay. Okay.
The patient age is around 50 years. You can scroll it and let me know what do you think about this.
Okay. I've been provided with sagittal cuts T2 for lumbar spine for the lumbosacral spine for patient coming with severe abdominal, with severe with back pain, which increasing gradually. The most important thing that I can see that there is evidence of just 1 second. This is 5, 4, 3, and 2. There is evidence of L2, L3, and L3, L4 disc herniation. However, I want to look for it in the axial cuts. Because I have concern that in this region that there is evidence of external neural exit foraminal narrowing and compression of the nerve roots, which may be cause for coda equina syndrome when it's go more progressed in its
I can
compression.
give you axial cuts then.
Okay.
Yeah, I have few axial cuts, so I can give you that. I'm sorry.
Okay.
Yeah, you can just take the axial cuts. I'm sorry we don't have that synchronization, but you just have a look at
no
the
problem.
coda
I will
equinus.
just okay. It's from down to upward. Here I think the level. Just 1 second. This is mostly the level. These two. Here I
Okay.
can see that there is a marked disc bulge with marked left side neural exit foraminal narrowing, and it causes cecal sac compression, and there is evidence also of the nerve root appear to be aggregated, and also I can see that there is evidence of mild ligamentum flavum hypertrophy. I couldn't see that there is evidence. Yes, and also there is evidence of facet osteoarthropathy. At this level also I can see it is the same finding with compression of the cecal sac and aggregation of the nerve root. From here it appears to be normal, and there is wide neural exit foramina and the nerve root appearing normal. So this is my main concern. This patient could develop coda equina syndrome. So this is an emergency. I want to convey my finding urgently for the neurosurgical team for appropriate management and the treatment for this patient.
Okay. So, do you think you have to? So, yeah, okay, all right. So let's go with the, how to see MRI. We are starting with the basic. Whenever MRI is given to you in UK, how their students are learning is they have been taught that first sequence should be this, second sequence should be that. If you have seen T2 first, you have to check the stir second to look out for any important safety finding. Safety finding here are two, always in case of the spine. First is coda equina, as you said, another is infection. So here, if you could see, if you have seen the stir image, there is a facet joint infection over here. This is the facet joint septic arthritis, which is causing a lot of problem. Gradually, I told you, gradually increasing just over 2 months. If it could have been disc, it could be sometimes sudden, it could be sometimes gradually increasing over a long time, or it can be variable. But whenever I'm saying this kind of, very short timeline, we always think of any neoplasm, maybe some metastasis or infection. This three things you have to always rule out whenever you are looking at the spinal MRI. So in UK, they have specific sequence or specific system to look at everything. So first T2 sedge, then stir sedge, and then T2 axial to look for anything else. So first you have to rule out whether there is any process within the marrow going on, whether there is any process within the infective process going on or not, and then you should move ahead. So and that was the only mistake, which was a big mistake which you made. Otherwise, everything was fine. You were not looking at it. So this eye you have to develop. There was something over here in that region. You scrolled it many a time. So always look for paraspinal muscles and psoas muscle to avoid infection, missing the infection. This is the important thing which I would like to tell. Then you can say that, this is a infection and I would like to immediately call the spinal team. This is emergency and we need to manage this patient urgently with the spinal team. Okay?
Okay.
You getting my point where the
Yes.
problem was? Because we don't have, again, that's the problem. We are very nice radiologists. We are thinking from our mind. Our mind is developed in certain way, but we need to train it like a robot so that we don't miss anything.
Okay.
Okay?
Okay.
That's the learning point from this. So now we are going towards next case for you. And this is again spine, lumbar spine. The patient is having gradually increasing lower back pain. And there is no stir images. In UK, whenever there is no stir images, that means
I was going to ask Mr. Image now.
so that's what I'm saying. There are two protocols. So this is another learning point. That's why I'm putting that kind of cases.
Okay.
In UK, there is a vetting system. Means radiologist has to determine what protocol they have to follow. So whenever they are just considering coda equina or they are just considering nerve compression, the clinician, they will just ask for spine general protocol or standard spine protocol for nerve compression. Then they will not take stir sedge image. But when they are asking for the entire spine protocol, when they are not sure, then they will take stir image. You're getting my point. So you can
Yes.
ask examiner whether the scan is taken in the standard protocol or whether it is the complete spine protocol. Then examiner will say that it is a complete, then you can ask for the stir image. So that shows that you know the system of UK. Getting my point.
Yes.
Now you can
Yes.
go ahead with this case, please.
Okay. This is just 1 second to scroll. Okay, so start scrolling. I've been provided with sagittal cuts of thoracolumbar and sacral also vertebra. T2. I can see that there is evidence of just 1 second, 5, 4, 3, 2, 1. This is T12 wedging fracture. Sorry. T2 wedging fracture. And I want to
Don't
look and
use the
also.
transverse arrows, just use vertical
Yes,
arrows.
yes, okay. This is a T12 wedging fracture. I can see that there is evidence of mild bulging through its inferior end. However, I couldn't see that there is evidence of any spinal cord compression or any abnormal signal within the spinal cord. In this T2 also, I am trying to look. I couldn't see that there is evidence of any perivertebral collection. Also, the disc space appearing, intervertebral disc space appearing normal. As this, I want to look for it also in T1 to look for the bone marrow signal for this. Okay. Okay, in the T1, it appears with normal signal, normal bone marrow signal. It does not show any hypointense signal noted. Just I want to scroll to see if there is any other abnormality. Okay. Okay. So I couldn't see abnormality noted within its signal. And at the same time, I couldn't see any other abnormality noted within the other vertebral bone. This could be maybe osteoporotic fracture, could be maybe old TB fracture, old TB infection. However, it's not acute because I couldn't see. I want to look also for the sagittal to be sure that there is no any other collection related to the muscle or the paraspinal soft
Would you
tissue.
like to look at the axials?
I want to look for the axial, yes.
There is another history for this patient, which I would like to give you further on, which you could have asked me as well, that it has
Okay.
radiating pain. That's why we've just taken the, the nerve compression protocol. It is left
Okay.
side radiated.
Okay, I will just. Okay, from this level, I will go up. Here in this level also there is evidence of marked narrowing of the neural exit foramina with cecal sac compression. So this may cause also radiating pain in the back. Just I will complete. Okay. All these levels appearing normal. Here there is evidence also of mild disc bulge, but here is normal. Okay. Just I want I'm looking for any other lesions, the spinal canal appearing normal. Okay. Okay. While I am going down, I'm looking also for the soft tissue. The aorta appearing normal. Both kidneys just show some cysts.
Okay, I will give you one section if you could identify something. I'm sorry, I'm because time is less, so I'm just
Okay.
directly giving you that section. Would you see something on that section? Would you like to comment anything from this?
In this section, There is maybe a cystic lesion here within the spinal canal, or just
So what it is known as?
sorry.
This lesion is known as what? This cystic lesion is known as what lesion? The name of the abnormality or any process related to this? How it
Maybe
arises?
synovial cyst or Tarlov cyst. I'm not. I want to look
Okay.
for it again in the sagittal view to just
Confirm
move
it?
on. Yes.
Okay, just a second. I'll give you that section itself so that you will be at ease. Yeah, if you could look at this section and
yes, could
you
be
could look at.
meningeocele, could be okay. Yes.
So, okay. Should I take it over from you?
Okay. Okay.
Okay. So this is known as the facet joint synovial cyst.
Okay.
Which is very common, cause of this neuritic pain in UK.
Okay.
And that in subcontinents, few cases are there, so we don't know about it. But this is very important cause over here. And why this is important? Because they have pathway for this. They use interventional radiology for this. It can be pierced by CT scan, CT guided thing, CT guided needling.
Okay,
Dry
so they
needling.
need aspiration only? Aspiration for
No,
the cyst
aspiration.
only?
It is known as dry needling. You're just gonna prick it multiple times so that it will be vanished, and just introduce bit of steroids so that it won't develop again. Okay. It's just a fluid-filled or jelly material-filled cyst, which is happening from the facet joint arthropathy, which is causing the nerve compression. So if I would be you, I could have said that I could have picked it up, which is a bit difficult. But if whenever this kind of cases comes, you need to ask whether there is a radiating pain. You need to draw information from examiner, because it is like, you are in the duty or in the MDT. You are allowed to ask them whatever the things are needed, because in actual practice it is like that only. You can ask them whether the pain is radiating towards any side, then examiner say that yeah, it is radiating towards the another side, because in the real practice you need to ask to the consultant as well the same thing. So if you could have asked me, I could have said that yes, it is radiating towards the left side, and then you could have checked all the left sides, and you could have picked this up and checked it up, and you have said that, oh, my final diagnosis is left-sided facetal arthropathy at L4-5 level, and there is a synovial cyst coming out of it, or ganglion cyst coming out of it, compressing the left traversing nerve root. I would like to correlate it with the clinical findings, whether it is hampering any thigh calf region or not on the left side. If it is, and then this is the diagnosis, I would like to inform this to the referring doctor and would like to arrange possible discussion regarding interventional procedure, CT-guided interventional procedure to prick this cyst and manage this patient, something like that. All right?
Okay.
So that's why I've taken these two cases. These are very important cases. Many a times this has been, discussed.
Okay.
So next case for you, I'm giving you this case. You need to start with the, axial images. And the patient has presented with 50-year-old male patient, and the ED clinician is suspecting bowel obstruction because there is constant vomiting. If you could have a look at the scan and rule out or rule in bowel obstruction, give your comments and manage this patient for me, please.
Okay. Okay. I've been provided with axial cut CT abdomen with contrast portovenous phase for a patient suspecting coming to the ED with suspecting intestinal obstruction. I will have a look and then I will comment. Just I will have a look until okay. This patient has multiple small bowel dilatation with a string of periosine appearing. There is evidence of no evidence of pneumatosis intestinalis, no evidence of pneumoperitoneum I can see. the ascending colon appearing normal. So I believe that this small bowel is within the ileal lobe. While I'm going down, I can see that the evidence of this or the cause of this intestinal obstruction, that there is evidence of hernia noted here. The hernia is lateral to the pubic tubercle, so I believe that the hernia is femoral hernia, a left femoral hernia. The hernial orifice does not show any evidence of free fluid or abnormal enhancement, so it's only incarcerated with no evidence of a strangulated hernia. And this is the transition point I can see here. Okay.
Okay.
This is very important. I will emergently convey my finding for the referring physician and for GIT surgical team for fixation of this hernia. Apart from this, I can see that there is evidence of gallbladder, large gallbladder stone. I couldn't see that there is any evidence of other than abnormality noted. And also for emergency, I have to ask the intensive care unit or A&E team for nasogastric tube insertion.
Perfect. This you nailed it perfectly. The purpose to put this case is, obviously just to identify this. This can be asked by the abdominal X-ray in the beginning, and they want you to suspect that inguinal hernia. There may be some bowel shadow at the level of pubic tubercle region, and they want you to say pertinent negatives, which you say like ischemia, perforation, ascites, any other problems. You need to tell them hernia. You need to say the type of hernia, whether it is kind of, the wide neck, narrow neck, something like that. So this case is related to the pertinent negatives mainly, and the management, which you said very nicely. So now we all are learning. We are all are going towards, what UK people are expecting. The another case for you, and this is a good case. Let's see how you are managing it. It is an incidental finding in MRI of an adult,
Okay.
and he has cervical symptoms.
He has cervical symptoms. Okay. I've been provided with axial cut MRI brain T2. Just I will have a scroll and then I will comment on. I can see, okay. I can see that there is evidence of abnormal hyperintense signal noted within the fourth ventricle of the posterior fossa. Just 1 second. Yes, it's marked hyperintense signal noted. I want to look for, and I believe that it's continuous with the posterior, the foramen magnum and cervical. Okay, just 1 second. I will have a look. Good look. This lesion, I think it's in the fourth ventricle, as I can see that there is evidence of bilateral temporal enlargement. So there is evidence of there is evidence of hydrocephalus, which I will consider it as an emergency. This is abnormal. I want to look for the signal of this lesion in other sequences. I want to look for it in flare and diffusion sequences.
Okay. Which sequence you want next? I will give you that.
I want to look for it in diffusion.
Diffusion. This is diffusion for you.
Okay. Sorry, 1 second. The only spot image, I think. I can see that there is evidence of restricted diffusion noted within this lesion. Okay, can I see it if there is any, I will compare it in the EDC to be sure that this is low intensity.
I'll give you ADC as well. Just a
Okay.
second, give me a control.
Okay. Okay, it's again a spot image.
It is not taking
Yes,
it, but you can
yes,
just have
and
a look.
it's a low intensity signal. So this confirms that this lesion has restricted the diffusion. Okay, is there is any post contrast image also, just to see if
Yeah.
it show contrast or not?
This
Okay.
is post contrast for you.
Okay, in the post contrast, it does not show any contrast enhancement. So this lesion in the fourth ventricle and show this marked hyperintense signal in the T2 with restricted diffusion in posterior fossa and no contrast enhancement. It could be epidermoid cyst in a typical location. Just I want also to uh, it will not be I want also in my routine practice I will look for it in the sagittal view just to see why the patient has cervical um, pain.
We have coronal instead.
Okay, it's extending, I think, downward. I believe it's extending downward to the spinal canal of the neck.
We're not sure about it, but yeah, okay. It can
Yeah,
go, there may be a, CSF issues, CSF pressure issues, which may cause the
yes,
pain.
this is an
But
emergency. Okay.
so, yeah, well, what emergency you are going to address first, and how you will
The
manage this case
hydrocephalus.
as well?
The
Okay.
hydrocephalus. This is an emergency for hydrocephalus. I will convey my finding for the neurology team for for shunt for this hydrocephalus and for MDT for discussion for this case and take the
All right.
action, appropriate
Perfect.
action.
Perfect. You did this case very nicely, but you could have cut it, a bit shorter because you got the diagnosis, and otherwise everything is fine. You took all the care which I have mentioned. No problem. So can we go ahead with the another candidate, please? The
Okay.
last
Sir.
one who wants to volunteer.
Hello, sir. Can you hear me?
Yeah, I can. I can. So your next case is within this packet only. Then I will change the packet. So
Sure, sir.
just go ahead with the next case for you. And first you will get the ultrasound of 25 years old of female, right upper quadrant, acute pain and tenderness.
Sir, I've been presented with the ultrasound images of the right upper quadrant in which I can see hyperdense
You can scroll it
lesion.
even.
Okay. Sir, I can see a hyperdense lesion and that is present, that is involving the upper pole of the right kidney, and it appears to obscure the border of the anterior cortex of the kidney, and with loss of discrimination between the border of the kidney as well as the gallbladder, and I can see the debris within the gallbladder as well. I would like to know the history of this patient. This hyperechoic lesion also has few areas of low density within. Um, so um, Sir, my first, I would like to, my top most differential in this case will be an angiomyolipoma that might be with an associated bleed. But however, I would like to confirm this finding on CT and inform this finding to the referring physician and take the history related to the patient.
I will give you CT scan. I have one. We did it. Have a look at it. Which type of the CT image you want?
So preferably post-contrast.
Okay, I'll give you post contrast then.
Sir, I have been presented with the CT image of the same patient, post-contrast images, in which reconfirms the finding of that hyperechoic lesion, which appears to be mixed heterogeneous density involving the anterior cortex, and there is associated mark soft tissue fat straining and a hyperdense fluid that is seen in the pararenal region. And it is extending to the suprarenal region as well. So again, considering the CT, I would re-diagnose it as a angiomyolipoma because there is evidence of fat content within it and the hyperdense area that is surrounding it within suggesting that there might be an evidence of an acute bleed within this angiomyolipoma. Now, I would like to refer this, I would like to inform the findings to the referring physician and also ask for the interventional radiology to see for if they can mask the bleed or help in the to stop the bleeding of this patient. And further, I would like to take the history and also confirm my findings with the previous scanning if there is a history of angiomyolipomas previously, and take the history of further related to as angiomyolipomas are associated with tuberous sclerosis. So I would like to confirm the history as well, and
Okay.
and associated brain
All right.
imaging if needed after dealing with the emergency of this hyperacute bleed.
Perfect. Another thing which you could see is, not in this case. So there is a checklist for every cases. For this kind of cases, you can ask for lung window, check for any lymphangioliomyomatosis. Sometimes there may be fatty type of low density pleural effusion can be there. That could be a chylous pleural effusion. And as you said, that tuberous sclerosis, you need to say, so here keywords are, acute finding, safety finding is bleeding and fat. So angiomyolipoma, whether it is increasing or not, it is in large in amount, so you need to flag it. Any bleeding vessels for that interventional radiology team, which you have also conveyed. So almost you have spoken up all the findings, and you also said that I'll manage immediately as well as refer this for to assess for the tuberous sclerosis spectrum. Simple word you can say that. I'll assess this patient once it has been out of the danger. Then I'll assess for the tuberous sclerosis complex, and then it will be the management. All good, perfect. Just give me a minute. I'll just
Sure.
change the packet. And one case is there still in this packet, then afterwards, the next one. So this is a radiograph for you. First, this one. And then I'll go ahead with this, another radiograph in this patient only. He's having back pain and a bit of difficulty in breathing as well. First, look at this radiograph. Let me know what do you think, and then we'll give you chest X-ray as well.
So I've been presented with the X-ray abdomen of an adult, in which the thing that I instantly note is actually this loss of pedestal in
Do you think it is
three.
X-ray abdomen?
Sir,
Does it cover entire abdomen?
no, sir, spine
Because
preferably, you can say. Yeah,
Mhm.
X-ray of the frontal projection, AP projection of the lower lumbar spine, in which the first thing I note is actually a lytic area that is involving the left pedestal of L2 vertebrae.
Mhm.
Apart from that, which is called as a winking owl sign. Apart from that, there might be some sacralization of the L5 vertebrae, and also the transverse process of no, it's patent. It's okay. The bowel pattern appears non-specific. Considering the rest of the bones, I am not able to see any gross lytic lesion elsewhere. The SI joints appears to be a bit like the joint space appears to be fused.
Okay, let's
Uh,
comment on this then. What do you think about this, and how you will
sir,
manage this entire case?
sir, X-ray chest frontal projection of an adult, in which the first and the most striking feature is actually the bilateral upper lobe hyperdense areas. Apart from that, there is asymmetry in the lung volumes, with left lung being more voluminous. So I would like to see if there is no evidence of deep sulcus sign, or I'm not able to appreciate very well because of the exposure factors, but I would like to see if there is any evidence of pneumothorax in this case or no. Uh,
So what you will do
And
next in this
there are
kind of patient?
fibrotics. Sir, I would like to have CT, and there are fibrotic strands extending out from the hilar towards the periphery. And also on the left upper side, there is areas of radiculonodular shadowing.
Mhm.
There's subtle widening of the uh, right paratracheal strip as well, prominence of the hilar, especially the right one. So, sir, I would like to do the CT for this patient to
So what is your
further.
diagnosis? Okay, which CT,
Yes, sir.
where you will send this patient? Something like that. Give me a proper diagnosis, what you will convey to the physician.
Sir, first, most important thing was actually the loss of pedicel. So, the loss of pedicel always normally suggest a metastatic lesion. So that should be immediately conveyed to the referring physician.
Okay.
Apart from
So
that,
you
in
can
the
say that
chest,
it
there
is a metastatic lesion with possibly lung primary, something like that, or
primary could
unknown
be, sir,
primary if you are not sure.
unknown primary, and the hilar is also very much prominent. And there is asymmetry, and the lung mets are also associated with the pneumothorax themselves. Uh, so, sir, I would
So
like to
what is your next? What scan type
the
you are
CT
going to take? Which
scan with the,
CT? Which
yes, sir.
areas you
Sir,
will
abdomen and,
mention?
so first the chest to rule out any pneumothorax first, and then and then abdomen as
Yeah.
well.
So there is a learning point from all of you. In UK, whenever you are suspecting malignancy, there is a staging CT scan. It is known as CT-TAP scan. CT thorax, abdomen, pelvis scan. So you need to speak this word.
Yes.
This word. Whenever you are missing primary, you don't know what is primary, but you are having some aggressive bone lesion or something like that. Always go for staging CT TAP scan and refer that patient to the relevant MDT, something like that. This should be the
Yes, sir.
words
Yes,
where
sir.
people are losing marks because this is easy. Everyone will get it. Examiner will put that the candidate is not able to manage the patient and he will put 5 marks or something like that, or maybe passing marks. Okay, so
Yes.
we need to say
Just
them the
abdomen
proper
comes. Yes.
management words. Yeah, the mark is for that. Okay, so yeah, just a moment. I'll just stop sharing the screen and we'll come back.
Yes, sir. Sure.
Are you able to see my screen now?
So I can see your name, but nothing is showing up yet.
Just a second. Now is it fine?
Yes,
Is
sir. I
it
can
okay
see
for you?
CT brain. Yes, sir. CT brain.
Yeah,
You're
okay.
sharing.
Yes. So this is 70-year-old female patient is like very difficult motor vehicle collision. She is having a, GCS score very low, just 3. Please tell me, what do you think about this patient? What is the problem at the moment and what to do next?
So I've been presented with the axial CT brain, uh, non-enhanced, in which I can see diffuse subarachnoid hemorrhage that is involving the bilateral cerebral hemispheres, extending on to from the base of the skull till the vertex. Also, uh, there is a mass effect evident by the effacement of Garai and Salkai. The ventricles are a bit pinched. I would like to see in the coronal and sagittal views to see the associated transtentorial and the herniation of the cerebral tonsils to the foramen magnans, because there is crowding in the posterior fossa as well. And I am not able to appreciate the fourth ventricle. So, sir, primarily this is actually diffuse subarachnoid hemorrhage in a patient with the motor vehicle accident with mass effect and brain herniation. Further, I
Any
would
other
like
thing
to.
which is concerning, which you feel that, there is something very problematic with this patient, which you have to convey right now at the moment?
Sir, there is subdural extraaxial hematoma as well
But there is
in
no
the
much
right
mass
frontal.
effect, isn't it? There is no much midline shift.
Yes, sir, there is no much.
What's the most important finding, if you could tell me, which I'm really concerned about? Patient may die anytime.
The acute bleed and
That's fine, but I'm saying something else. How the death happens, there are three systems: airway,
the
breathing, and
herniation,
circulation.
because sir, there is air that is air that is noted in
That
the
air
region
can
of
be
the
because
cavernous
of,
sinus.
IV drug
Yes,
infusion, that are cavernous sinuses, the air may go.
the most important thing is actually the herniation, that we should
What
immediately.
type of the cerebellum you are seeing? Any idea about that? The cerebellum is. Could you please comment on cerebellum specifically?
Yes, sir. As I already mentioned, that there is evidence of crowding in the posterior fossa with evidence of cerebellar tonsillar herniation into through the foramen of magnum.
Other than that, the density of cerebellum
Sir, it appears to be hypodense, the white matter, while
as compared to rest of the cerebral parenchyma.
sir, there is sir, it white cerebellar sign,
Hmm.
like
Yes.
is a diffuse hypodensity of the brain. Sir, hypoxic ischemic insult, like um, a global bilateral cerebral hypoxic ischemic encephalopathy with right cerebellar sign.
Yeah.
Uh,
Yeah. Yeah.
that is
So, yeah,
actually.
what you will
Yes,
do now?
sir,
What are
immediately
you
I will.
concerned about? Any specific
Uh,
word you are concerned about? This patient is going towards what?
that maybe there is transection of the internal ICA of the ICAs or the blood
No,
supply
no,
to the
no, no,
brain.
no. Okay, let me take it over because we are short of time. So here, the main word they are trying to ask you is whether you know the imminent brain death or not.
Yes, sir, brain
This
that's
patient may go to the brain death finding because of this global hypoxia. And this patient is almost on the verge of death. Whatever the reason may be, the blood is lost, the patient is having less amount of blood. Basically, the perfusion is low to the brain. The main systems are not getting proper blood, and patient may die any time, any moment. So they want this imminent brain death, possible brain death due to global cerebral hypoxia. Plus everything, whatever you have said, that's fine. But this word is important.
yes,
Okay.
sir. Yes, sir.
Yeah. Then next case. Yeah. This is the another patient for you, and I'm giving you clinical presentation. This is a 55-year-old female with back pain and bone and soft tissue pain, bone pain mainly. What do you think?
Sir, X-ray chest frontal projection of an adult, in which I can see in bilateral lung fields, I can see multiple small reticular nodular shadowing, more of a nodular nature. Apart from that, the right CP angle is okay, but the left one is like there appears to be more hyperdense lesions uh, within the uh, left lower lung.
That's
The
projectional.
car
You can omit it.
Yes, the
That's not
cardiac.
that important.
Sir, the lung is sorry, the heart is appears to be enlarged. Uh, so apart from
I
that,
want the cause of back pain and bony kind of pain.
sir, I'm not able to appreciate the thoracic spine through this very well. But
Any causes you know about the back pain, bone pain in elderly patient more than 50 years old?
sir,
Generalized
it can,
back
sir,
pain,
I
bone
can see
pain.
generalized decrease in the bone density. More of, like it can be related to meds, sir. It can be because of myeloma. It can be uh,
Okay, okay. So what you will do
so,
next then?
sir, MRI spine preferably.
All right. And myeloma workup. I'm sorry, I'm going a bit fast. It's just,
Yes, sir.
the diagnosis is myeloma here, and there are multiple tiny, lucencies within the ribs
Yes, sir. Within the
and,
spine.
the clavicles. If you see the left clavicle, it is difficult to pick. Many examiners' favorite case this is. Please always think about this whenever gonna hear elderly patient, bit of pain. You should know this. This one, if you could just go through it rapidly and tell me. So
Sir,
that was the myeloma case. You should say that I'm just going through the management. You should say that I'm suspecting this patient with multiple tiny lytic lesion. It could be myeloma, it could be metastasis. I would like to go ahead to discuss this patient with the clinician. For this, would like to send this patient for the bone lesion MDT to further work up myeloma, and we can decide about MRI or the bone scan for that patient, something like
yes,
that. Okay.
yes, sir. Yes,
So
sir.
always what my kind of narration is, try to join pathways. Don't try to
Yes,
give them exact management because you don't know. They are also radiologists. They are not the clinician. You don't know what is there in their mind. Go towards that process which is safe. Go towards the MDT. Try to suggest them what could have been done during MDT, something like that. Don't speak specific treatment whenever, unless there is a exact need like pneumothorax. You can say that introduce the drain or something like that, or interventional technique where you know the management. Then you can say the exact management. Otherwise, you don't need to. Okay. Please go ahead with this one. This patient is having the bone pain, 55-year-old female, and there is a known chronic disease process going on. If you could let me
sir.
know,
Yes,
what do you think?
sir. Anterior and posterior projections to bone scan, in which I can see generalized decrease uptake in the spine, in the axial skeleton. And one of the very important striking feature is that the no uptake in the kidneys, which makes it a super scan. So also there is increased activity in the pelvis. The most common cause for this can be hyperparathyroidism. It can be uh, myelomas as well.
What
Uh,
is the
so, uh,
distribution
so axial
of
skeleton.
the uptake? Axial
So mostly,
skeleton. Okay.
so it can be METs, myeloma. It can be like less likely hyperparathyroidism, and
All right. So
most.
what you will do with this patient? I said it is a chronic process. Patient could be there for many a times. This could be another one investigation. So what you will do?
Sir, immediately refer the finding to the referring physician and compare with the previous studies to see if these are
Yes, you
additional
need to
meds.
speak this word, compare with the previous
Previous
studies.
studies.
Okay, that is important. Whenever I'm saying chronic, that means always think about as if you are in the, real charge. Always pick up that there are certain words you keep practicing so that it will be in automatism at the moment, because you have to think, you are not able to speak it on time because you don't know, you are not in that kind of process. But here what happens is they have NHS is centralized system in entire UK. They have database of all patients since 2000 or before that, 1990s even. So they have all the old scans, all the old records available in their DICOM or the servers. So we can have a look at any old scans. So whenever the chronic process is there, whenever the long-standing things are there, you always have to ask for the old scans or old images. Okay.
Yes, sir.
All right. That was the learning point out of this. Otherwise, everyone will say that, this is a bone pain, this, that, everything. So metastasis, as you have said. But once you look at the previous images, I will say that, yeah, there is a breast cancer in the previous images. Then you can say that it could be that, and you can send the patient to the maybe PET scan or MDT, something like that. Okay.
Yes, sir.
The next case for you is A patient with the suspected small bowel obstruction. If you could tell me, what do you think about this patient?
Sir, X-ray, sorry, CT axial images,
Patient's
post-contrast.
age is 18 years.
I would like to scroll through whole of the images before I come up with the. So there is evidence of small bowel dilatation and fecal loaded large bowel. 18 years, sir.
Yeah.
So there is says there is bowel wall thickening and fluid levels and dilatation that is more centered upon the jejunum.
Don't approach like that. I'm sorry, I'm just interrupting you. My clinical question is any. See, you can't
Yes, sir. There
just
is.
stop it. You have to give entire opinion, whether there is obstruction or not. I'm a
Yes, sir.
clinician.
It
I have
appears
asked
to
you
be.
that.
Yes, sir. It
You
appears
can't
to be
expect
a
me as a
closed loop.
radiologist, you know. You
Yes.
can't expect me to be a radiologist that I do understand wall thickening, these, that. You
Yes.
tell me your opinion. What do you think? The final opinion.
Yes, sir. It appears to be a closed loop obstruction more localized in the jejunal loops. That could be related to some internal hernias or adhesions if there is any history of operation before. I would like to scroll. I would like to see the coronal images to see if there is any to correlate with my findings if
I'd like to
available.
check pancreas.
Yes, sir. The pancreas is atrophic. I mean, it is replaced by the fat. So, sir, the most common diagnosis in such cases is actually cystic fibrosis.
Mhm. And
Um,
whether there is obstruction or not, what type of obstruction it is, and how it happens. So you need to give your observation, then interpretation, diagnosis, and management. How you will answer that?
Sir,
Okay, let me tell you this. If suppose I'm coming across this case, what I will do is any intestinal obstruction case, I will start looking from the stomach itself. If it is coming, I will look trace the entire bowel loops first. I can see that I can't detect any transition point, but I can see that there are fecal material and the dilatation is still the rectum. And everywhere it is fecal material. So I can suspect that there may be a dynamic type of obstruction or there may be stercoral obstruction due to hard feces. Now, in this age group, I would like to look at the pancreas. I can see that it is fatty atrophic. So, at this age group, with the hard feces, the only possible cause in my mind for the mind comes is cystic fibrosis with distal intestinal obstruction syndrome. And I would like to immediately convey this finding to the referring doctor, would like to arrange for the urgent surgical referral with the cystic fibrosis clinic review for this patient and would like to manage by enema and the treatment for the cystic fibrosis,
yes,
something
sir.
like that. All right, there is a separate cystic fibrosis clinic in UK, so you can say that
Yes, sir.
you can send that patient to that, but you need to pick up these findings. All these
Okay.
cases are very important. Trust me, these are very important cases. Many times they used to be discussed. You know, uh, last case for you and for today. After that, we will discuss certain important things for exam, like what to read, how to read, all that. If you could just go through this case, this is a safety finding. I want you to pick it up immediately. The patient is
Um,
having breathlessness.
Sorry, sir, I'm
The
not able
patient
to.
is having
Yes, sir.
high BMI.
Sir, I can appreciate pulmonary embolism in the
Or,
right pulmonary
okay.
artery.
So
However,
what you will
the
do, how
main
you will manage?
sir, immediately inform the referring physician and ask for the um, embolectomy and also anticoagulation for this patient.
Okay. All right. So yeah,
And
that was the
also
safety
advise,
finding. Yes, please go ahead. Yes.
sir, ask for the ultrasound to see any associated DVD.
So whenever, yes, ultrasound is also there, and whenever you are saying this pulmonary embolism, I'm sorry I interrupted you, but just saying, always speak about the right heart condition, whether it is strain pattern or not. Right heart is enlarged, almost same, or what kind of, and pulmonary artery is enlarged or not. Always say whether it is acute pulmonary embolism or chronic one. Whenever there is calcification, it may be chronic. If there is no calcification, it is acute. So the diagnosis should be like that. There is acute pulmonary embolism involving this pulmonary arteries, and there is a right heart strain pattern or no strain pattern, something like that, without any associated lung mass lesion or infarction. All right. And I would like to immediately inform this finding to the referring doctor and to arrange for the further management like anticoagulation and a consideration for the vascular team referral. Something like that. You are not saying what to do, like embolectomy or something, that they will decide, vascular team. So, this is the kind of endpoint for us. But now the most important thing comes up, today's resolution. So, this exam, as I told you, is all about from one clinical question to final clinical pathway and get the safety findings right. So, how to prepare for this? Dr. Khan and their people, they form very nice version of the Chapman. Chapman is the book which I would like to, show you how to read it. And it has everything for, this exam. I will just show you how to read that. And most of the things will be solved. I mean, you will get the cases, you will get the idea what kind of the cases can be asked. And from that, you can just, see that kind of cases in various portals, and it will be very, very useful to all of you guys. I'm just sharing my screen. Are you able to see my screen, the Chapman? Let me reshare my screen. Are you able to see my screen?
Yes, it is.
All right. So how to read Chapman? Most of the cases are this underlined important diagnosis, and there will be this kind of the case most of the times. And another cases are your two A scenarios, whatever the were there in your MCQ books in 2A, the similar kind of the cases they may be asked, and your 2B books as well. But if you are going with the differentials, like what you should think, all this, underlined ones are very, very important diseases that can be asked. If suppose you see skeletal metastasis, first, if there is a lytic, I have shown you the case, you look for the lung. Same way, super scan is also there. Almost cases are there out of this book. So if you have 6 months in your hand, then you can go for this book. Or else, whenever you are finding something difficulty that you are not able to pick up the diagnosis, nothing comes up in your mind, what to think that you are not able to think about, this book will be good to go, because this book will teach you what to think if you see a particular finding. So there are two things which people are having difficulty with. One is the spotting the finding, and another thing is what to think next once you get one finding, whether you can link it with other or not. So spotting the finding, to spot the finding, you have to see a lot of cases. You have to assess in a particular clinical situation what could be the possible finding happens. Like as I told you, right upper quadrant pain, these are the findings. If there is a bone pain, these are the differentials. If the chest x-ray comes with this particular symptoms, these are the differentials. So that kind of practice we are going to do in upcoming sessions, like if this film happens, what you have to think. And that's the spotting part. Another thing is linking part. So if you are not able to remember what could be the possible causes, this underlined words, underlined things are good to go. Only that are the cases. Non-underlined are not the cases in this particular scenario. Most of the times, underlined words are the cases. So this Chapman book is very good to go book. And another thing comes up is safety finding. The third thing comes up. For that, I would like to show you something that RCR has given this kind of guidelines for, the safety findings. This is a list. If you search in Google, safety finding RCR document, they have everything for every system. And most of the cases, these are your passing or failing cases. If you miss this finding, there will be a CNS case. If you miss a hemorrhage, if you miss a mass effect, or if you don't speak up this in a particular condition, you may lose mark. Herniation syndrome, any stroke-like features, intracranial infection or empyema, unstable fracture, tension pneumocephalus, spinal cord compression, or any vascular stroke, thrombus, any kind of the thrombosis. So these are the findings which you can't miss anytime. These are the safety findings. This is the list. We will improve this list. I'll give you the final list which I have formed during my exam. So these findings I don't want you guys to miss. So just go through this finding. Whenever you are thinking about, develop your eye or develop your mind in such a way by doing repeated scrolling, by going through the things that you should see all these things first within just 5 to 10 seconds. Now, third component comes is the time, because we have just 15 minutes for one viva and you have to go through at least 4 to 5 films. So how you will manage? One film should at least 3 to 4 films, I should say. So one film should take not more than 3 to 3.5 minutes, which includes you have to see the image, you have to speak up, and you have to do everything. So you need to match your time. You need to be like a robot. If you think more, then the time will gonna go out of your hand, and then the pressure builds up, and you will do the mistakes. You will start speaking everything, whatever comes in your mind, and then the problem starts. Examiner will mark as the scattergun approach and will mark you as an unsafe doctor. So then that problem is the main problem. You need to consider and respect the time. So for that, the only possibility is whatever I have said to you, go through that scenarios, understand that if this kind of condition comes, this could be the management. And final thing is what I'm trying to say is Houdini's approach. Houdini, magician who used to get out of any kind of the bars or walls or any kind of problems. So here the Houdini's approach is whenever you are not knowing anything, just go as a safe doctor. Try to ascertain all the safety findings. Try to look at the possible scenarios which you have come across. If you still don't know, you go with the clinical symptoms. So you go with the imaging strategy. If suppose acute abdominal pain is there, what could be the imaging strategy? First will be the ultrasound. Then if directly CT scan is there, then the another you can go with the further imaging, what kind of CT scan or any other causes of that. So go with that particular imaging strategy, the approach. Then you will be considered as a safe doctor. So always first follow the rule of the common scenarios. If you are not able to detect anything, then look for your specific safety findings. Still, you are not able to see anything, then go with the, if suppose that case came, like bone pain or something like that happens, then in the end, you see that there is a, this kind of patient comes, elderly patient with this. What could be the imaging strategy? Imaging strategy says that there could be myeloma or metastasis. So you should say that in this patient, the possible causes could be that. Though I am not able to see anything in this one, I would like to discuss with my colleague or with another clinician regarding this, and we can plan further MRI, or we can send this patient for the MDT, or we can take the lateral views, something like that. So basically, what they are assessing is your ability to give a proper opinion while you are on duty or MDT. That's all. It's not about you have to give exact pinpoint findings. Sometimes you may miss out the findings, but your approach should be right. Then they will mark you as a safe doctor. You are safe and you will pass the exam. But if you speak everything, they will mark you as a scattergun, unsafe doctor, and that single case will kind of make you fail, even though you get all the cases right, because RCR says that there is no place for unsafe doctor. So just mind that. Always follow this. First, the common scenarios, then safety findings. Still, you are not getting, go to the imaging strategy, and finally, manage towards that pathway which is safe. So these are the things which I would like to convey. We are going with, different cases every time so that you will be familiar with all kind of different aspects. And as I told you, what to speak is very important. Just speak observation, like what you have observed, which is relevant to the clinical context. Don't speak all the observation. Rest observation, if it is important, like gallstone was there in that particular case, in the case of the intestinal ischemia, or in the case of the hernia obstruction, you can say it in the end, as the candidate also said it in the end. But the main clinical context was obstruction. The clinical question was obstruction. You have to answer that thing first. You have to answer the clinician's clinical question. And always ask, whenever you feel that the information is not adequate, you can ask examiner, not asking, but you can saying that I'm suspecting there may be a radiating pain. If there is any radiating pain, I do consider this, I do consider that, something like, form a scenario, form a statement. If that, something like that statement, you can form it up so that that will give you a bridge time. You will think about something else, you can scroll the images, that kind of thing will exist. In exam, there may be problem with scrolling. At that time, you can ask examiner, would you like to scroll it for me? Or if there is any lag, can I scroll it slowly? They may give you a bit of extra time as well. So these are the things which are very important. And as we did the cases, you must have learned a lot of things. One is the management thing. Another one is the what are the different kind of the protocols are there. Third thing is how you need to manage the patient, when to ask for the urgent concern and when to ask for the MDT. And what are the particular syndromic scenarios which you need to keep in your mind. These are the main take home points with this lecture. I think all the cases something to learn, different scenario, different perspective, what to do in terms of management, something like that. So this is what I want to tell you. And these are the things, if you get all these things right in your spinal manner, you practice, and it will come up as if we are driving, everything comes up automatically. Same thing will happen to that, and it will be in your mind memory, I should say. So any questions for today from any candidates, I am happy to answer, and the feedback as well. Anyone, candidate one, would you like to ask any question? Would you like to say something? Candidate one.